Good morning, teachers and colleagues. Today's presentation is on a 29-year-old female resident of Neuro, housewife with no comorbidities, presented with memory disturbances since 1 year. Difficulty in difficulty in understanding speech since 1 year, imbalance while walking since 1 year, and decreased vision since 6 months. Past history, at 8 years of age, she had seizures which was not evaluated. At 14 years of
screen move नहीं हो रहा है मोनिका.
Now, sir.
नहीं स्क्रीन मूव तो नहीं हुआ अभी भी 29 ईयर फीमेल वाली स्लाइड पे.
स्लाइड शो पे डालो मोनिका.
हाँ, yes ma'am. Now it is changed.
चेंज हो रहा है. चलो कंटिन्यू.
Past history, at 8 years of age, she had seizures, which was not evaluated. At 14 years of age, she developed multiple cutaneous painless swellings all over the body. In 2016, she had increased frequency of seizures, which was started on anti-epileptic drugs, but not evaluated. In May 2017, MRI brain was done. There was 4 centimeter lesion in temporal cortex with multiple lesions of about 10 to 15 mm over the scalp. That time she was told to observe and follow up. Family history, there was no significant, and she is not a child of consanguineous marriage. Personal history, no comorbidities, no addictions, and no bowel and bladder disturbances. And there is no delay in development of milestones. Marital history, she is married and she has 2 children, and there was history of neonatal death at 1 year of age, due to septal defect. On general examination, patient is moderately.
फिर से तुम्हारी स्लाइडें मूव नहीं हो रही है. तुम वो उसको स्लाइड शो पे क्यों नहीं कर रही हो?
स्लाइड शो.
हाँ तो स्लाइड शो दिखाओ ना. तो ये पैसे बोलने से क्या फायदा? हाँ.
Monica, that at the right hand bottom corner, there's that extreme right, there's a small symbol. No, click on that. It will go into the slide share mode. So automatically when you press, it will change the slides.
Now it is changed, ma'am.
No, it is still in that other mode. It's not gone into slideshow.
I think I'll.
चलो तुम ऐसे स्लाइड चेंज करो.
On general examination, she is moderately built, moderately nourished, and she has multiple neurofibromas, which are painless, and there are capillate spots. These are neurofibromas, and there are capillate spots. And on CNS examination, she is a right-handed person and higher mental functions. She is conscious, oriented to person and time, and not oriented to place. MMSE is 10/30, which is poor cognitive function. And in the speech, fluency is preserved, and there is no repetition. Naming is there, and there are neologism. And cranial nerve examination, she has decreased vision on the left side of the field in both the eyes. And there are no sensory and motor and cerebellar deficits. And ophthalmic examination, there are no iris nodules. Impression, in view of she has neurofibromas and capillate spots. She is having an F1 phenotype with query optic glioma at the chiasma and glioma in temporal region, temporal lobe. She was evaluated outside in the KM hospital. MRI brain in December 15th. It was showing 7 into 5 centimeter lesion involving left corona radiata, basal ganglia, left parietal and periventricular region, left medial temporal lobe, and left crus of midbrain with midline shift of 11 mm to right and uncal herniation on left. There are small nodular lesions in right frontal lobe. And there are 9 into 7 mm lesion in the suprasellar region, likely involving optic chiasma, likely neurofibroma. And there are multiple nodular enhancing lesions in parietal, frontal, temporal, and occipital scalp, suggesting neurofibromas. She underwent left temporal craniotomy and excision of the left temporal glioma on 26 December in KM Hospital. And intro-op, the lesion suspected to involve basal ganglia and internal capsule was left behind. And biopsy is reviewed in TMH. It was showing low-grade glioma with on IHC it is positive for P53 and it is negative for IDH1 mutation. And tumor cells show retained ATX protein expression. And it is also positive for OLIG2 and negative for CD24. In this case, the possibility of pilocytic astrocytoma is considered in view of neurofibromas. And post-op MRI, compared with the pre-op MRI, there is irregular post-op resection cavity in the left temporal region with stable surrounding pericavitary hyperintensities on T2 flare, showing elevated choline, likely residual disease. And there are 3 small enhancing lesions in the right frontal lobe and internal capsule and optic chiasma appearing suspicious. And multiple enhancing well-defined lesions diffusely involving the scalp were neurofibromas. This is a T1 flare image with the hypointense with pericavitary hyperintense query residual disease. Thank you.
Okay. So first of all, you give a summary of the history. Then we'll have discussion on history. Then we'll go on examination.
Yes.
So summarize your history in history.
She is a 29-year-old with no comorbids. She had seizures at 8 years of age. First seizure onset is at 8 years of age, and she has multiple neurofibromas with kephilite spots. And she has a 7 centimeter lesion in the
temporal. History summarize karo. Don't go for physical examination and radiological findings. So your history says that is around a 29-year-old female who has
seizure
now has some neurological symptoms, and she has a which is of long-standing duration, and she has probably has a related seizures at when she was at 8 years of age. And on history itself, you can see when they're talking to the patient that she has neurofibromas. Perfect. So, if such a patient comes to you who has a long-standing history of multiple neurological complaints, what are the differential diagnoses you are thinking of?
First is neurofibromatosis with glioma.
Forget for this discussion that the patient has neurofibromatosis. So let's say that. So tell me something. What are the kind of symptoms which will point to you that this patient has a lesion in the brain?
So she has memory disturbances.
Let's say that the patient has a lesion in the brain. So what are the such symptoms which will point that the patient has some lesion in the brain?
She has memory disturbances.
Don't tell about she. In general, what are the things which you get in history will suggest, okay, this needs me to do some imaging because the patient probably would have some lesion in the brain. After that, we'll come to benign, malignant, everything.
Any headache, vomitings with seizures?
Yes, so that is fair enough.
Focal
you have a headache, vomiting, seizures. So you will have that is perfect. Acha driver bata hai. Tell me something more.
Any focal neurological deficits?
So what you must say, Monica, is now any sudden onset headache, vomiting, or even seizures, you will go for imaging. That's no doubt about that. Okay, severe headaches, you will only for headaches you may go for imaging. That is very unlikely. So something which is going on for a pretty long time and it doesn't fit into any of the headache syndromes, you would go for imaging. But most of the time the patients have history, like someone has migraine, then you would have some fair amount of history which is going for the headaches. focal neural. See, so what I'm trying to tell you is, keep most of the time when you think about lesions in the brain, the history is going to be subacute or kind of a chronic history, something which is going on for 2 months, 3 months, or 6 months. It doesn't mean that it cannot come in acute, but most of the times your history will be like that. Most of the symptoms are non-specific. You cannot actually say that the patient has a brain tumor or yes. So most of the things, non-specific CNS symptoms, when they don't get resolved, you need to subject the patient to imaging. So that's the first thing which you take away from this class, that non-specific CNS symptoms, which are like headaches, which are not getting resolved, you need to image the patient. Specific things like if the patient is having seizures and if he's not a known case of has a history of seizures prior, a new onset seizure in adult needs to get imaged. Next, like a subacute occurring focal neurological deficit, which localizes to the brain. You need to get, for that matter, if you localize the spine, you need to image because it can be something other benign also. You need to image the patient. So first think about it like that when are you going to image the patient, because there is no way you can say that this is glioma only, this is neurocystic sarcosis, this is tuberculosis. So coming to that, let's say that you image the patient. Okay. So how do you decide that the lesion if which you are seeing is, let's first talk about whether it's benign or malignant when you image the patient radiologically. So the imaging of choice has to be an MRI. How will you decide that this probably is benign, this probably is malignant? How do you decide that in imaging?
Most of the extraaxial lesions are supposed to be benign.
Okay, but we are not talking about extraaxial lesions here. Let's focus on axial lesions. So when Monica meant by extraaxial, which means something which is coming from the meninges.
Meningium.
Yeah, so let's focus on parenchymal lesions right now. So how would you say? थर्ड ईयर कौन है भाई? कोई है क्लास में थर्ड ईयर? हेमंत है? हेमंत?
Yes, sir.
हाँ बोलो भाई हेमंत. So when you see a parenchymal brain lesion, what are the indicators? So no one can be perfect, that is perfectly benign or malignant. What are the indicators you start saying that this is benign and this is malignant?
Heterogeneous enhancement and control.
Okay, so let's put things very simple. Okay, so first you will see whether it's a single or multiple lesions. Okay, so see the MRI when you do, you will have a T1 image, a T2 image, you would have a contrast image, and there are multiple other kinds of scenarios. So let's go with 1-1-1-1 and let me explain you. So the first thing you see is whether single hai or multiple hai. If you see multiple lesions, the chance, the probability that there can be brain mets increases. Not that multifocal glioma nahi hote, but then only 2 or 3 kind of things. So if you see multiple lesions, your probability of having brain mets increases. Second, your progressive tuberculoma also increases with multiple lesions. Specific locations hota hai. Next is locations, like whether it is at the gray-white matter junction or whether it's the gray matter. Gray matter, white matter junctions is commonly seen with brain mets. Mainly in the gray matter, it is something mainly glioma kind of lesions. But gray-white matter, like for mets, you can even have neurocystic sarcosis been seen there, or tuberculomas also arising from those lesions. The next thing, so what you start seeing is, let's say that it's a single lesion, which is something commonly seen with abscesses or neurocystic sarcosis. Whether you are seeing anything, you need to have high definition imaging, whether you are seeing any scoliosis or anything of those kinds. The next thing you start seeing is, so first is, if you ask this question in exam, start whether it is single or multiple, what is the location of the tumor, what is the characteristics of the inside of that lesion, whether you are seeing any scoliosis. If you are seeing some calcification, then the things that it is benign. And if it is malignant, उसमें oligodendroglioma है, that starts picking over. Then location also matters. Like certain locations like hypothalamus or through that one insular cortex, if you see lesions in those cortex, most of the times they tend to be towards malignancy. You don't commonly see that many benign lesions coming in this kind of situation. What I mean by benign lesion is like space occupying lesions. Don't see in this kind of situations. Okay, so these are the things which you see. You also look at whether there is a prior history of malignancy or not, which or whether there is prior history of malignancy, whether this is something which goes to the brain or not. So these things, so whether the site है, कौन से whether numbers क्या है, site क्या है, location क्या है उसका, उसमें what are the features of the lesion itself. Then also you look at what is the how does the brain react to the lesion. For example, is there edema? Is the edema disproportionate? So when you see glioma related edema, it is nearly with a similar smaller rim around the ear. But when you see brain mets related edema, the lesion will be small, but the edema will be large. So disproportionate edema hai to brain mets ki taraf jayega. But what you see is that most of this feature can pinpoint towards a few things that okay, this might be this might be this, but cannot most of the time exactly say unless you get classic pictures. So next things which you try to say is whether there is necrosis inside the lesion, or if there is a cystic degeneration inside the lesion. So cystic degeneration, neurocystic psychosis में मिलता है, pyelocystic astrocytoma में मिल सकता है. When you see necrosis inside the lesion, then you are more okay. It might be an abscess also, or it might be a tumor also. What helps also is, as I told you, there are multiple sequences in MRI. What is happening with the contrast? Whether there is enhancement with the contrast. Enhancement अगर है, मतलब there is more about neovascularization happening. That whatever pathology is, it is attracting more of vascularization. So for us, we always say it can be a tumor, but vascularization can even be attracted by developing abscesses. So you need to have get a perfusion scan done. You need to get spectroscopy done. Now, when you look at spectroscopy, it doesn't tell you that this is tumor or benign. What it tells you is what is happening to the surroundings. Like for example, whether there is damage to the neural tissue or not. If there is damage to the neural tissue, what kind of byproducts which are being produced. Now, when you look at this, whether it is damaged or not, and whether what kind of byproducts, and then you have signatures which would probably tell you that this is more towards benign, this is more towards tumor. So understand that when you see an imaging, all these factors will help you to make a decision. But there are a few things which I will put it in place. Like for example, a 40-year person suddenly having a subacute kind of a neurological deficit with a lesion in the brain. You need to know that there is the more the age goes on, the probability that it is going to be a malignancy, the probability keeps on increasing. And it's not uncommon that you think that this might be this, and you remove the tumor and it turns out to be something else. So with this diagnostic dilemmas, we'll leave that topic there and we come to this topic. Well, this patient, because he had neurofibromas all over the places, and so when you see something in the brain, you think that this is probably a glioma picture is there. So tell me, Monica, in an adult, we won't fall into pediatric discussion that you do in your pediatric postings. In an adult, if you see a lesion and on imaging, it looks like a glioma. Okay, it's a single lesion, limited amount of edema associated with it. It is not enhancing. So what I'm trying to hint is it is not a high grade glioma. It is certain, it is homogeneous also, it is not heterogeneous, which means it is not grade 3 also. So these are the features which make it. So if your lesion is enhancing, has necrosis, you would say a grade 4. If it is no necrosis, no enhancement, but only heterogeneity, you would see grade 2. So it's a single lesion, it is homogeneous. On the signature, it seems that this patients may have glioma. So what would you do with this patient? Let's say in this 20-30-year-old female, she would have come with such a lesion. And I'll give you 3 scenarios. 1, the lesion is frontal. 2, the lesion is in the temporal lobe. And 3, the lesion is in the insular cortex. Tell me, what will you do?
If it is in the frontal, radiation can be avoided.
Dear Monica, अब तक सिर्फ radiological signatures आया है. You don't know whether this is benign or yeah for sure. Don't you want to do get a pathology out for something for pathology?
Yes.
So what will you do? चलो हेमंत क्या करेंगे?
Sir, first we need to, if a lesion is in frontal or temporal lobe, we need to do biopsy first.
Okay. So another thing. Let's go one by one situation. Frontal, temporal, insular, we'll take one by one. Okay. So
Yes.
if the lesion is seen in the frontal lobe, okay, looks like a probably kind of maybe a lowish grade glioma. There is no role of going ahead and doing a biopsy, seeing there is a glioma and going again. Okay.
Yes.
The neurosurgeon will go and going for something called as a maximum safe resection. Okay, which means he will remove that whole tissue which is looking abnormal. Okay, and send it for pathology. And that's what you want to do. Let's say that it is that lesion of glioma may turn out to be something else, but then still that surgery becomes a treatment for it. If you do a biopsy, you will have to subject the patient to an again repeat procedure and come to situations where you would do a biopsy. So you do a maximum safe resection. Why do you do a maximum? Why would you do a maximum safe resection? The reason why because if it turns out to be glioma, all the resection has been done, near completion, it is better. Okay, so if you maximum safe resection. So let's go. This will do for frontal. Same thing you will do for temporal. The problem comes in insular cortex where you have middle cerebral artery, which is very near. It's a complex part also. So what I'm trying to tell you is, you talk about maximum safe resection. So how much ever it is safe, you are going to resect. So how do you define how much you resect? So if you remove everything, whatever you see, you remove everything, that will be called as total resection. If you could remove 90% of the chunk of what you're saying, you would say it is 90% or more, it's going to near total. Anything between 50 to 90%, you would say that subtotal. And anything less than 50%, you say is that's biopsy. Okay. This holds true for whether it is benign or A. So this is the way you classify your resection. Now, frontal, you have a chance of removing a tumor completely. Frontal lobectomy can be done. So is temporal lobectomy can be done. So only thing which you see here is when you do is when the neurosurgeon plans some this kind of area is whether eloquent cortex are involved or not. And if the eloquent cortex are involved, they would go for an awake craniotomy, at least in adult, to see that the minimal neurological deficit is done. So when we say maximum safe resection, it means it has to be done as much as the resection can be done, which is without trying to give any neurological deficit to the patient. Things change when the things are deep-seated, like it is in thalamus, it is in the insular cortex. Okay, something which is near to the internal capsule. You can sometimes get gliomas there also. Most of the times, however, gliomas which come at this side are high-grade gliomas unless they come up with this NF1-like features. In that situation, to approach to this such situation, this is difficult. But you need the biopsy, first for histological diagnosis, second for molecular analysis. In that situation, you will go for a stereotactic biopsy. So your answer in exam should be very clear that you would do a maximum safe resection whenever possible. And what you mean by maximum safe resection is you would resect as much as the tumor is safely possible. What you mean by safely, that there should not be any neurological deficit to the patient. How do you make sure that neurological deficit doesn't come to the patient? You would do imaging for that. That means you would see something called MRI tractography to see how the tracts are going around the lesion. If it's clear, you could resect it. You take care of doing an awake craniotomy as it's an adult patient. You can do an awake craniotomy, so you are sure that if you are resecting that area, it may not lead to a neurological deficit to the patient. In situations where doing a surgery is going to be harmful to the patient, or the approach towards the lesion is going to do more neurological deficit, like when the lesion is deep-seated, like in case of thalamus, in case of insular cortex, where there are a lot of eloquent areas around, or if the tumor is in an eloquent cortex that's sitting over the speech areas, motor, you would remove as much as is safely possible. Okay. So when we say biopsy, it means that the lesion has been removed less than 50%. So that is the definition of biopsy. When you would do biopsy open you will do when you, something is in the eloquent cortex, you say, okay, I will do a awake craniotomy, I could remove as much as safely possible, I'll try to remove as much as possible. When you would go for a stereotactic biopsy, you're sure that it is a deep-seated tumor in thalamus, areas near such a where you know that doing an approach or open is going to be harmful to the patient, then at that time you go for a stereotactic biopsy. So are we clear about when you're looking at a lowish grade tumor, which is on radiology, how do you approach surgically? Samajh mein aaya?
Yes.
Okay, good. So let's say that surgery is done for this patient. So this is so in these three scenarios, frontal surgery, open surgery, maximum safe resection, you may not take care of awake craniotomy also. Temporal, you will need a awake craniotomy. You can go for temporal. Insular, you probably will go for a stereotactic biopsy. Okay, so this is the way the situation span out. Let's say that the patient has undergone, and this is the commonest scenario where you will step in. Patient has undergone surgery with a neurosurgeon. Okay, and it has come out to be a, let's say for this discussion for today, because we are doing today with low-grade gliomas, first we'll give a common situation, that is it has come out to be a grade 2 glioma. It has come out to be a grade 2 glioma. And the patient comes to know that you are a renowned oncologist from Tata Memorial Hospital. So he has come to you for a second opinion. Take this situation, 29-year-old female, no comorbidities, no neurofibromatosis, has undergone a resection. The scan which you are seeing is the scan which the patient has brought to you. What will be your opinion? ये रवि है क्या?
Sir, yes, sir.
रवि है क्या रवि?
Sir, yes, sir.
हाँ बोलो रवि. What will you do in such situation? So let me repeat. 29-year-old female has undergone the resection. The MRI in front of you, the MRI is one of the sections which the patient has brought to you. And in histopathology, this has come out to be a grade 2 glioma. So what all you need, and tell me why.
First, we will look at the risk factors, sir. So we will consider the age of the patient, and then post-op residual, we will see whether the post-op residual is there or not. So looking at this MRI picture, since the patient is having looking like significant post-op residual.
Okay, fair enough. What else will you open to the patient?
Sir,
Opinion क्या दोगे?
we will consider it as an high risk, sir, and then we can consider for RT along with chemotherapy, sir, temozolomide.
Okay, that is fair enough answer. So what would have been good if you would answer this? So when such patient comes to you, you look at Harris factors. 2 Harris factors for adults. Age greater than 40. So this patient is age less than 29. The second Harris factor is there is presence of residual disease. How much residual? Residual has to be more than 1.5 centimeter. Okay, that was the way it was initially defined. But then they saw that even if small residuals are there, the patient not do badly. So you in your practice stick to if there is residual or not. Quantifying residual is very difficult. So because the patient has a residual, this would get classified as a high risk grade 2. If the patient's histopathology would have come as grade 3, then what would have been your, and there was no residual, what would you have done? Ravi, क्या करते हैं? Grade 3 आता, कोई residual नहीं होता. 29 years.
Sir, RT, sir. We will consider we will go ahead with RT with concurrent temozolomide.
Okay. So good answer. So listen, when you say grade 2, you look at risk factors, whether it is high risk factor is present or not. Age more than 40, more than or equal to 40, or presence of residual disease. Any one of presence of these makes it the high risk factor. If it is grade 3 on histopathology, or even if in pathology it comes out to be grade 2, but you are seeing the scan of the patient, which was pre-operative scan, and the scan shows that there was heterogeneity, then it should be taken as grade 3. So remember, like BST, in neuro, you look both at the pathology also and at the radiology also to make a decision on grading. Okay, is that clear? Are we clear?
Yes.
Yeah.
Yes.
So if it is grade 2 on pathology, but the scan is showing heterogeneity. So why this discrepancy happens? Because when we sample some proportion of the tumor. We cannot sample each and every slice of the tumor. Okay. So remember this. Now, so this is grade 2 high risk. What he says is correct. What I would have done is something more, and I expect you to tell in exam something more. You not only say that this is a grade 2 tumor, you go for a molecular classification of this glioma. You'll at least look at first this IDH mutation. Okay? IDH mutation, you can do an IHC. If IHC IDH mutation is positive, well and good. This would behave like a IDH mutated tumor. If IDH mutation is negative on IHC, you will order for a sequencing, at least a single sequencing for IDH mutation. Around 20 to 30% of patients which come negative on IHC will come out to be positive. Remember, now the WHO has changed. For you to tell that the tumor is a low-grade glioma, you need to have an IDH mutation. If there is IDH mutation negative, the patient most of the time behaves like a glioblastoma. So if this patient would have been a grade 2 glioma, high risk features, but IDH mutation after doing everything would have been negative, I would be concerned about the patient that he's not going to do as well as a grade 2 glioma. He's going to do something similar to a glioblastoma. If the patient is IDH mutation positive, and if the histopathology suggests that there are oligodendroglioma like cells, then you would go ahead and do a 1p19q deletion analysis, and that's done by FISH at present. If the patient is 1p19q positive, then you would label this as an oligodendroglioma. If it's 1p19q negative, you label this as an anaplastic astrocytoma. Quite a few times people don't have 1p19q analysis facilities at the institute. At that time, a rough surrogate would be, again I'm telling a rough surrogate, 90-95% correlates or 100 is ATRX. ATRX, it's an IHC. So if the patient has ATRX retained, then there's a chance that the patient will have 1p19q loss. If the ATRX is lost, then most of the time there is no 1p19q loss. So you can also classify on the basis of ATRX, because sometimes 1p19q sometimes take times to come and you need to have a decision early. Okay, so this patient comes to you as a glioma, two things at least you will order is IDH and ATRX, and depending on the reports, you can go ahead and order for 1p19q analysis. Now, why is this necessary? This is necessary because when you look at the management of grade 2 glioma, and now we'll take a few steps backwards. So we have been asking question to Hemant and Ye. और कौन है थर्ड ईयर में? ये सहायक है क्या? I don't think Sayak is there. Pritesh?
Yes, sir.
Good. I can see you. So my question is, let's step back in this patient is residual disease. Let's come back to this case. She's a 29-year-old female, and let's say that she had a single episode of seizure for which imaging was done. You saw that there was a temporal lobe of space occupying lesion where the neurosurgeon has done a complete resection. There is no gross tumor seen, so we would say it's a GTR, gross total resection, and it has come down to be grade 2 glioma. It is IDH mutated. It is 80 RX loss, so which means it is not 1p19q deleted. Okay. What would you offer to this patient? Ritesh, तुमसे पूछा है.
Yes, sir. I would still offer post-op RT to the patient, sir.
Fair enough answer. My question to you. I give you 3 options. Observation, RT, or giving temozolomide alone. Tell me the pros and cons of each of them.
Okay. Sir,
नहीं बोलो, सोच के बोलो, मैं मदद कर दूंगा, कोई बात नहीं, चलो मैं ही बता देता हूँ. So first, observation. It's a fantastic option. Patient doesn't get any side effects of neither of radiation, neither of temozolomide. The problem is that you are afraid that the patient will have recurrence. That's one thing which you have in mind. अरे इसको recurrence आ जाएगी. Second thing which you have in mind is that patient may have transformation. So what they say is that the low-grade glioma over the time may become a high-grade glioma. So second concern with your observation is the transformation. The third concern is that if the patients, see, when we say gross total resection, which is macroscopically, there is no tumor. You don't know whether microscopically tumor is there or not there. So the concept in CNS is something different. It's not like head and neck, a margin was cleared or not. We don't know whether the margin was cleared or not. And en-bloc resections are not that commonly performed in neurosurgical procedure. Now there is a trend going towards doing an en-bloc resection. Most of the time, these are like piecemeal resections which are happening. So your concern lies, okay, observation, a good strategy, avoid side effects, but what about recurrence? What about transformation? What about that patient may develop neurological deficits or starts having again seizures? So there was a study done by URTC, which was specifically for this situation. Grade 2 gliomas, which low-grade gliomas, they were randomized to early RT versus RT at recurrence. The results of this trial was very clear. Obviously, giving early RT led to a better PFS because you expect that RT has been given to better PFS, but there was no difference in overall survival. Coming to whether quality of life was improved in patients who received early RT, no, quality of life was not captured in that study that well, so you couldn't talk about whether quality of life improved. What was seen was seizure frequency. The frequency of seizures this patient had were higher in the patients who were in observation arm, but this was limited to the first year. After the first year, there was no difference in the seizure frequencies between the patients in the two cohort. Third, the concern that this will go and progress into a secondary transformation to GBM was similar across both arms. So the moral of the story is, in a grade 2 glioma, which is a low risk, where there is no residual disease, and if the patient is a very good follow-up candidate, okay, and especially if the patient did not have seizures prior to the, so it's relatively seen that those patients who had seizure prior to the resection, those are only the patients who have seizures afterwards. Patients who didn't have seizures prior to the resection do not, I won't say do not, but are unlikely to have seizure episodes after surgery. So if this is a good patient who is reliable for follow-up, who would get you a scan done regularly, what is the definition of regular plan? At least 6 monthly for the first 2 to 3 years. Doesn't have seizures previously. Understand that the disease will come back, and it will come back in around 30 to 40% of the patients. That is half of your patients. And wants to avoid the side effects of radiation and temozolomide. He is a good candidate for that. So, am I clear, Pritesh? Who will you keep on observation?
Yes, sir.
So let's go to the other option of giving temozolomide. So let's go to radiation, because that is classically the aim. So it's a safe strategy. Patient grade 2 glioma hai, radiation de do. Do you have evidence for that? You always have the evidence of your study that though the OS was not different, the PFS did improve. Okay, but it is also known that if you give radiation when the disease comes back, it also takes care of it. They always used to be concerned that radiation देने से जो secondary progression है to glioblastoma, that may actually increase. But again, the URTC results suggest that whether you keep an observation or not, the transformation rates were the same. So that is not done. So if the patient is not that a very good follow-up candidate, or if the patient has very residual disease, or the patient has a history of seizures prior to EEA, prior to the surgery, with the presenting features of seizure, it's better to give radiation, which will be like a 1.5 month course of radiation. Here itself, I'll finish off how much dose of radiation needs to be given. There was after the first URTC low-grade tumor, there was a second study done by URTC. What they did was they compared a dose of 45 gray to 60 grays. And they saw that giving 45 grays itself is enough. 60 grays is not required. So normally people will tend to give a dose of around 50 to 54 gray in this situation, but a dose of around 45 to 50 gray, conventional fractionation 1.8 to 2 gray per fraction is enough in this situation to be taken care of. Now, the third scenario, when would you consider giving only temozolomide to the patient? So there was a study done by Dr. Rogers too, in which what he did was he compared in one arm low-grade glioma, no high-risk features, but he compared with temozolomide versus radiation. It was a non-inferiority trial, and the non-inferiority was met. However, it was seen that the events were higher on the radiotherapy side, and events were higher, which the recurrence was slightly higher on the temozolomide side and slightly lower on the radiotherapy side. And this was seen even in the 1P19Q cohort. And that's the reason why many people are not so excited about these results. But it goes without saying that in this trial, the endpoint was met, non-inferiority was proved. So if someone says that I don't want to take radiation for 2 months, I don't have the time to take radiation for 2 months, and logistically impossible to take it me for 2 months, temozolomide given for 12 months is a good option, which means temozolomide, the good thing is that it is 5 days a month, and so does not interfere much with the patient activities, and has side effects of profile of grade 4 of around 10 to 14%. So most of the patients won't get it. So a good regimen to be given. So what I'm trying to tell you is observation, RT alone, temozolomide alone are all options for low risk grade 2 glioma, which means that it is grade 2, age is less than 40, and there is no residual seen in the post-operative MRI. And this is another one point which I want to clarify. Do not go with the word of neurosurgeons. However experienced they are, it has been seen in multiple studies that neurosurgeon says gross tumor resection is done, but in the post-operative MRI, you will see that residual is there. So your decision should be based on a post-operative MRI, and this post-operative MRI should be done either within 48 hours of surgery, so that no edema has been set, or after 3 weeks of surgery. Don't do it in between, because you would have post-operative changes and edema setting up, which will confuse you whether there is a residual or there is no residual. Sometimes post-operative, there are certain bleeders also there, so you would get confused whether what's happening. So do it within 48 hours, which is considered the best before any edema sets in. If no, which is because many of the places don't have the infrastructure for a neurosurgery operated patient to get the imaging done within 48 hours. In that situation, you get it done after 3 weeks. So am I clear of what you would do in an adult grade 2 low risk glioma? Keshav, समझ में आया क्या?
Yes, sir.
Okay, good. So let's come to the situation when this is grade 2 and high risk. Now, when you say grade 2 and high risk, the actual standard is RT followed by PCV regimen. and this came on the basis of RTOG 9802. This is the topic of the next class of management of grade 2 glioma, so I won't go in detail today. RTOG 9802. So 2 arms were made. One arm received RT, one arm received RT plus PCV, and it was seen that there was a dramatic survival improvement of around 20% in patients who received PCV along with RT. So my problem is giving PCV is difficult. I'll show you the difficulties of PCV in the next class. So temozolomide may be a reasonable option in this situation. Okay. There are 10 minutes left. For 10 minutes, I will take a topic which you may choose to forget if you want to forget, because unless you are practicing neuromedical oncology and that too in an expedited center, these cases are like this neurofibroma is unlikely to come to your clinic. So who is there? Let's take now. Rahul is there. Rahul, so if you get, let's say, a grade 1 glioma in an adult, how common it is to get a grade 1 glioma in an adult? ये राहुल है क्या? तो ऐसे ही ऑन करके भाग गया है?
नहीं, sorry sir.
Okay. Tell me how common it is to get a grade 1 glioma in adult. राहुल तुमसे पूछ रहा हूँ, अगर 100 लो ग्रेड ग्लायोमा आएंगे तो कितने ग्रेड 1 होंगे अडल्ट में?
So around 10%.
Very good, that's correct. What is the features of grade 1 gliomas? राहुल तुम क्या गूगल करके आंसर दे रहे हो क्या?
नहीं सर.
इतना डिले क्यों आ रहा है? तो आ रहा है बोलो, नहीं आ रहा तो नहीं आ रहा है बोलो.
No sir, no idea.
कोई बात नहीं, space some 5 minutes on this. So low grade glioma grade 1 is basically a pediatric topic. And why is a pediatric topic? So if there are 100 patients which come an adult with a low grade glioma, 90% are going to be grade 2, what you call a diffuse low grade glioma. Grade 1 is seen only in 10% and that's correct answer now. Converse is true when you see pediatric. 80%, 75 to 80% will be grade 1, 20 to 25% will be grade 2. Okay. Location भी adult में different रहता है. Pediatric, you must have seen pilocytic astrocytoma coming in the infratentorial region. So it is 30 to 40% of their gliomas will be infratentorial. Adult grade 1 are mainly supratentorial. Okay. So let me come to this now. Let me say that you are a renowned medical oncologist and you are the only practicing physician that a neurosurgeon does a surgery. It comes out to be an adult, 30 years. Now let's be specific, NF related, because they are going to be NF related. And you see that the patient has undergone surgery and has come to you. Okay. So, Abhishek hai? Abhishek, you are there?
Yes, sir.
Okay. So let me repeat my question if you are not listening. 30-year-old female, न्यूरोफाइब्रोमेटोसिस है. आप जोधपुर में प्रैक्टिस कर रहे हो, वहां न्यूरो सर्जन ने ऑपरेट कर दिया, आया है कि ग्रेड 1 ग्लायोमा है. यू आर सस्पिशियस. आपने टाटा सैंपल भेजा, आपने डॉक्टर अनीता बॉल्टिस के पास भेजा, आपने और 2-3 जगह पे भेजा, सब जगह से आया कि नहीं भैया ये ग्रेड 1 ग्लायोमा ही है. हाउ विल यू अप्रोच दिस पेशेंट?
Sir, for grade 1 glioma, we consider for observation.
Okay. So your answer should not be that, Abhishek. Your answer should be, you will assess the post-operative MRI. Okay.
Yes.
Whether there is significant residual or not. Okay. What I mean by significant residual? Residual is at such a place where if it increases, it will lead to some neurological harm to the patient. Okay. Or the patient may not be a very good follow-up candidate. You feel. ये भाग जाएगा. In these are the situations. So if it's completely, what you're saying is correct. If it's completely resected, that is gross total resection has been done, patient will be for observation. But if it is not completely resected, or there is a very small residual seen, but the patient is not a good follow-up candidate, you will consider treating this patient. All the classical indications for treating are: one, there is radiological, there was nothing and the patient has progressed or has recurrence, which is not amenable for resurgery. So again, I repeat, let's say this patient who came to Abhishek in Jodhpur, 30-year-old female with neurofibroma, he didn't have a residual. Abhishek has kept her on observation. After 3 or 4 years, she comes back with another tumor. Abhishek will subject that tumor again for resection. Again on observation. Again a tumor comes. Again a resection. Again observation. You understand? Unless this tumor is not amenable for resection, or the progression is very fast. Let's say it's coming back in 6 months, less than 1 year, then you would consider some form of treatment needs to be given. Okay. So Abhishek, let's take this case. 29-year male, female has come out with a low-grade glioma, which is at a critical site and has a residual disease which is left. What will be your treatment in this case? Neurofibromatosis है, ये ध्यान में रखते हुए पहले बताओ.
Yes, sir. Sir, if it's as a critical structure radial disease, we consider for the post-op party.
Okay. Why not post-op chemotherapy?
No idea.
Okay, good. Fair enough. Shashwat?
Yes, sir.
अरे शाश्वत तुमसे पूछ रहा हूँ भाई, आ रहा है तो आ रहा है बोलो, नहीं आता तो नहीं आता है बोलो.
So post of no idea about chemotherapy.
No idea. Okay, chalo. Let's focus on this case for next 5 minutes. So when you're talking about neurofibromatosis, okay, understand that the response to chemotherapy is very high. Okay, most of the data comes from pediatrics when they want to avoid RT for 2 reasons. One, because the child is growing. So traditionally, if this low-grade glioma, we're practicing Jodhpur, there's no pediatric person, it will come to you. So it's seen that in such situation, when the child is less than 10 years, you try to avoid the RT so that there is no cognitive decline. Understand that low-grade glioma patients are going to go for long. We're trying to avoid cognitive decline. We're trying to avoid damage to the hypothalamus pituitary axis. We're trying to avoid damage to the optic nerves and the optic radiations. Now, this is fine for the pediatric patients. When you because of these reasons, I want to delay the radiation, which is fine. But the good thing is, when you give chemotherapies in such low-grade glioma, especially in neurofibromatosis, the 5-year progression-free survival stands somewhere between 70 to 80% with chemotherapy alone, which means that the chances of recurrence are really less with chemotherapy alone, even if you give. The long-term control rates at the end of 10 years is 40%, which means that most of the patients, if you give chemotherapy, will receive 1 or 2 lines of chemotherapy at least. And that's the way pediatric people will push the patient beyond 10 to 12 years and then give radiation. Now, what you said is correct also, that, okay, we can give radiation, but I would have expected that answer, and I would have been okay with that answer if this patient was non-neuro, non-NF1. Because a non-NF1 patient, the 5-year chances of control is only 40%. For an NF1, the 5-year chances of control with chemotherapy is 80%. Second, when you give radiation in neurofibromatosis, and I expected this answer from Abhishek, that the brain is sensitive to radiation. It is one of those conditions which makes brain sensitive to radiation. So the chances of having damage to critical structures is increased. Secondly, it has been known in neurofibromatosis that when you give radiation to the brain, the chances of getting secondary tumors because of radiation, it increases. So you would, in a neurofibromatosis, give radiation when it is absolutely required, okay, and would delay. And that's the reason why in this patient, Monica didn't show you ahead, the plan is to give chemotherapy. Understand, this is a very rare situation. In Tata, I have seen 4 or 5 cases over the last 5-6 years when you may be probably seeing 1 or 2 cases in your lifetime. Okay, but this is the way you would be managing this patient. So my question to Sobin is what are the regimens which you give in low-grade glioma patients? Sobin, you are there? Okay. To be diplomatic, also there is some technical error on Sobin's side, and we'll continue the discussion. So the regimens which you give in low-grade glioma patients are multiple regimens are there. First, single agent vinblastine, which goes for 1 year. Second, VCR carboplatin, vinblastine goes for 2 years. Single agent vinblastine, which goes for 2 years. VCR carboplatin, which goes for 1 year. Cisplatin etoposide has also been shown to be given. There's a regimen called TPCV, which is thioguanine, procarbazine, cyclophosphamide, vincristine has been given. Temozolomide single agent has also been given, but we have very good long-term data with vinblastine, vincristine, carboplatin. So these are considered to be the treatment of choice in this situations. What are the chances that if you give vinblastine to the patient in an NF1 that he won't progress within the next 5 years? The chances is 74% that he won't progress. In a non-NF1, the chance is only 40%. And that's the reason why if you do the non-NF1, I would have said, okay, go for radiation. Non-NF1, you would prefer to give chemotherapy to the patient. Naveen, you are there?
Yes, sir.
Okay. What are the common mutations which are seen? So let's say that this was an NF1 patient of low-grade glioma. I gave vinblastine, she does fine, and at the 6th year, she has progressed. I give VCR carboplatin, she does fine for the next 4 years. At 11th year, she again progresses. And he challenged with vinorelebin, she does good for another 3-4 years, and she progresses. So are you aware of any mutations which are there in this situation of low-grade glioma and for which some new drugs are coming?
Whether she's having any histone mutation.
I can't hear you. Jol se bolo.
Histone mutations.
No. Absolutely wrong. Histone KI3 mutations are seen in pediatric glioma, that is correct. But they are bad tumors, Baba. So if you see a histone mutation, I will give everything. They behave like a GBM. In these patients, you see BRAF mutations commonly. Okay, there's a mutation called KAIAA1504, which is the commonest mutation seen, followed by BRAF V600E. The interesting thing is that in most of these low-grade gliomas, the MAP kinase pathway is activated. And there's now very good data coming up that patients who have progressed after 2 lines, 3 lines, when we are giving selumetinib, selumetinib was given without any testing for MAP kinase activation. In this patient, the response rates to the tumor beyond 2nd and 3rd line was 45%. And the duration of response was for 3.5 years on an average. So now selumetinib phase 2s have shown, and now actually phase 3 has been run by a COG in which they are comparing selumetinib against carboplatin VCR as a first-line regimen. Same way, if you have this BRAF mutations, you can start tremetinib, and with tremetinib in this situation is nearly 100% disease control rate. So understand this is a rare topic, but understand that once in a while you may get this low-grade grade 1 tumor for an adult. The way you approach is whether this is NF1 related, whether it's tuberous sclerosis related, and whether it is non-syndrome related. If it's NF1 related, even if the patient is residual, please choose chemotherapy because the chances of damage with radiations are high. You can give actually multiple lines of chemotherapy, which can be, in fact, in the next class, I'll show you a few slides on low-grade management also, like PCR carboplatin, vinblastine, vinorelebin, You can re-challenge with these drugs also. There's very good data. The data mainly comes from children and adolescent patients, not so much from adults. So it's an extrapolation of data. If it's a tuberous sclerosis related, like a SEGA, in which mTOR inhibitors does very good. So that's the way approach you should do. If it's a non-syndromic related low-grade glioma, and if there's a residual, yes, you subject the patient to radiation. Okay, not that chemotherapy does not work. So if this patient progresses after that, you have in grade 1 tumors the options of giving vinblastine, vinorelibin, carboplatin, VCR. These are what is called as low-grade glioma protocols, which are there. Anyone if has any question will take, or it's already 9:35. No questions? Good. Ajay. So Ajay, you're
Yes,
there?
sir.
Anyone
Yes,
is
sir.
going to present?
Sir.
So the remaining activities, some solid 2 presentations for ISMP which are going. So if anyone is interested, they can remain. The rest all can leave. I would request students from solid 2 to be present on the further part.